Thank you very much for inviting me. I'm very happy to join you and to speak about the things that we experience in our daily practice. Well, I have some scientific experience, but I've been looking at the bereavement after suicide. So we established our unit, suicide prevention unit at the psychiatric hospital 4 years ago. So our team has expanded. We have more colleagues now, and today I would like to give some insights in what I have observed, when speaking to my colleagues. Well, when we work in the area of suicide prevention, well, we face clients, the majority of whom are thinking about suicide. They are suicidal, or they have made a suicide attempt. So I will share my experiences and the observations of my colleagues. Well, of course, losing a patient is a very big shock. Well, we tend to focus on what the relatives go through after a person's suicide, and we forget to mention clinicians, specialists. They are left somewhere, they are invisible, and there's often this impression that they have no human feelings. So I'm very happy that today we can speak about this. We can say that specialists also have feelings, and they don't become lesser specialists because of that. So it is very good when clinicists can share their feelings. Well, and sometimes we do everything we can, but people still commit suicide. And a suicidal crisis is not something that you can remove from a person. And specialists are not always successful in doing that, despite their competence, their attention, and professionalism. So no matter what we do, we sometimes do experience a client's death. So at our hospital, we sometimes say that we all have our own cemeteries in our heads. So in my presentation, I will try to describe the experiences and speak about the ways of preparing for such events. So a few words about what is going on in hospitals. Well, sometimes municipalities have plans, and as if prepared for events like that, but there are no algorithms that would allow to provide responses. And specialists are often left on their own, and they have to actively seek support. Support is not offered. When our hospital established a suicide prevention unit, we decided to include support for specialists into our algorithm. So our procedure is as follows. Well, our staff usually discusses the event, that is the patient's suicide, within the unit. Well, our unit employs only psychologists who provide advice to patients in all units of the hospital. And we usually organize team meetings if a patient commits suicide. During those meetings, we share details that were important during contacts with the patient who died by suicide. So we try to share our feelings. We try to share our insights on what has happened, why it happened. And I've heard from my colleagues that these meetings are really useful. So these meetings post suicide are very useful because they allow specialists to share within their community. We also discuss the interventions that were made, the services that were provided to the client, and we try to think whether things could have been done differently. And sometimes these meetings are called audit meetings, but I don't like this name because it implies certain blame. Well, the most important thing during those meetings is to make sure that everything has been done, everything that could have been done has been done, and we try to discuss things, but not to criticize anyone. Well, and we try not to learn from our mistakes at that meeting. Well, we can learn later on, but these meetings are devoted to sharing our feelings and thoughts. Well, specialists who feel that they have been affected, greatly affected by the client's suicide, can have individual meetings, and we also have a contract with the crisis center where our suicide prevention specialists or other staff can go and get help if they don't want to talk to a psychologist at the same hospital. So this is what we do, and I'm very happy to see that colleagues from other units approach us and ask us to come and talk to them. However, not everybody does that, and there is still a lot of stigma and a lot of isolation. So what are the feelings and thoughts of our specialists? A very important thing is that, well, we often don't even find out about our client's death after our clients are discharged from the hospital. And we sometimes receive this information from the relatives of the person who call us, or information reaches us in a different way. And for example, well, we sometimes find out about it from our clients themselves. For example, in a session with a client, and the client tells me that his suicidal risk increased because a close friend committed suicide. And I then realize that I know that friend. So how can I work further? How can I try and disassociate myself from that other client who committed suicide? So this brings about a lot of confusion. I also try to carry out research and surveys on bereavement, of the next of kin, but I didn't focus so much on the specialists. But specialists can experience real bereavement if they got close to the client, especially if they've worked with the client for several years. So what are the feelings and what are the responses? So the first response is increased sensitivity, a lot of reflection, and fear for other patients who are at risk. And this fear can really throw you and can severely decrease your self-confidence. And I have observed that some specialists, because of that fear, try to avoid asking clients about their risk, or they tend to start caring too much, and this might even lead to preventive hospitalizations when it is not completely necessary. So this fear and concern for other patients becomes a problem. And there's also the fear of being persecuted or being dismissed, being laid off. Well, Jacinta mentioned that there is this conviction that a client's suicide is a mistake by the therapist. So this fear is very real, and when a therapist feels this fear, it might be very difficult for them to accept certain comments because they might be regarded as criticism, or therapists might be afraid of those comments. They are afraid of being blamed or being laid off. Another feeling is anger. Anger, it can be anger directed at myself. Well, a therapist might think that, well, there were certain things that I didn't notice, or I noticed but was unable to help that person. There also might be anger directed at the system itself. The therapist might feel that he or she is left alone. Well, I have lost several patients over the last 4 years while working at this unit, and during the previous 4 years while I worked at another unit. So I lost a total of 5 patients, and I noticed that I felt anger at the patients, at the clients themselves. Well, sometimes I had questions. Why didn't that person call me? Why didn't that person share more? I believe that these questions are natural, and this is not an attempt to dismiss my own contribution or deny certain things. Well, this is a normal feeling that is experienced by many therapists. And of course, therapists tend to think a lot. They tend to overthink. They go back to the documents that they prepare. They try to think whether they have done everything that they could. They also try to think of different scenarios. And I've also noticed that the colleagues tend to rationalize all those questions. And this is not provoked by, as if this is not provoked by fear or anxiety. They try to rationalize those questions. They try to look for ways on how to work with clients differently. Well, yes, there might be some lessons learned, but this should come about later. Well, at the beginning, therapists also need to internalize certain things, and the questions that arise are a natural process of bereavement. Well, during the survey, when we talked to the relatives of people who died by suicide, we noticed that the relation with the deceased person does not cease to exist. Well, people who have lost their relatives by suicide continue to talk to those people, and therapists do the same. We usually remember those clients, we remember the way they spoke, the things they said. So on the one hand, this is a natural process. On the other hand, if we don't allow us to go through these things, those memories might become an impediment when working with other clients. And we might tend to overreact. So that relation continues to exist for some time, and memories don't disappear. For example, sometimes I see a patient who died by suicide on the street, although that client is dead. Well, but this is natural, and I believe that this is a natural part of our profession, and we need to live with these things. Another aspect that I wanted to mention is avoidance. Well, we've noticed that bereaved people sometimes avoid speaking about what they are going through, avoid sharing their experiences. And that avoidance is also a characteristic of therapists. There are certain myths that surround bereavement and suicide, and there are also myths and convictions about therapists, about what being a professional therapist means. So there is a conviction that professional therapists has to know how to disassociate himself or herself and have no feelings, because if you have feelings, this means that you are not professional or not good enough or not competent. But I believe that it is not that you don't have feelings, but it is your ability to regulate and manage feeling that helps you to be a professional. But, well, you have to react. I have told myself that when the time comes that I don't react anymore, when I don't have feelings anymore, this means that this is the time for me to change the profession. Well, another thing is loneliness. And what can help here? Well, it is very important to have a team or a closer colleague with whom you can discuss those feelings of bereavement while preserving confidentiality. You can also talk about this during supervisions or during your personal therapy, because you can't talk to your relatives because of confidentiality and because of ethics. Well, we can only speak about the way we feel, but you can't describe the entire situation to your relatives, to your close contacts. So a good way out is to share this with your colleagues during supervisions and tell that story. You can tell, well, it is very important to tell the story of your client, or to tell your colleagues what you spoke about. And you can discuss your feelings of bereavement, not only after suicide. You can talk to your colleagues during the process while you're working with the client. And it is very important not to avoid thinking about it yourself, discussing it with yourself. And we shouldn't think what is allowed, what is not allowed. Well, you should allow yourself to feel, and self-care is very important. Because after a client's suicide, the boundary between your professional and personal life disappears. It is very difficult to say that, well, this is my work, well, bereavement is part of my professional work, and it shouldn't spill over to my personal life. This is not possible. You need to remind yourself that in your personal life, there are other parts of your personal life on which you can lean. You can lean on your friends, other people. And you should be aware that your profession is not your entire life. And if you start doubting your profession and your competence, you shouldn't feel hopeless in all areas of your life. You should also try and use your resources. You should follow your usual regime. Another important aspect that helps you manage your feelings is documentation. Well, this is a very usual part of work when you're working in a hospital, but documentation is also important in private practice. Well, when a client dies by suicide, it is not impossible to remember everything. And if you have your notes, you can go back and this can be your support. And you can see that, well, I responded in that way based on the information that I had on that during that moment. In order not to feel lonely or alone, it is important to communicate about the event within your organization and within your team. You have to know that your team will not punish you, will not blame you, and it is important to speak about it. Sometimes it happens that we hear about the event within your organization, but that event is not widely discussed. There are audits, there are checks, and there is a lot of fear. So it is very important to communicate the fact within the organization, to present the fact neutrally, with respect, and with support to the team that lost the patient, because the death of a patient is not a matter for one team only, it's also a matter for the entire organization and the entire society. So therapists cannot be left to deal with this alone and in silence, because that could affect their work with other patients. So communication is very important. A therapist who lost a patient should feel the support of the team and should feel part of the team.
And another thing that can help the bereaved person, that is to be prepared emotionally. And the question is whether it is possible to get prepared emotionally. Yes, it is. And 100% you will not be able to do that. But you have to think this over. You prepare yourself inside. The team gets prepared as well, and it's necessary to have the team, at least one colleague to share with, a clinicist, a doctor, specialist, working together, and professional cooperation is also very important, because then you have the possibility to reconsider the loss if it happens, and then you share the responsibility, because that means that you were not the only one to bear the whole responsibility, and you do not feel the omnipotent. You do not feel that you need to blame and shame yourself. And the moral preparation starts with allowing yourself the idea that there is a possibility that a patient, a client, may commit suicide, because this is the reality and it does happen. And to what extent do I allow this possibility to myself? How do I feel about that? And the preparation starts at this point. And this is the reconsideration of myself as a specialist and as a person. This helps accept the reality, the part of work and that you experience. And this is also responding to all possible questions related to suicide and mourning and bereavement. What do I think about those people who get suicide, or people mentally diseased? And this is not an equation between the two, by the way. These are two different questions. Don't I sometimes get the reaction from certain stereotypes or convictions or prejudices? Is this reaction not encouraged by the feeling of indefiniteness? And do I allow myself to think about this sense of hopelessness and the sense of the fact that the fact that I can experience that?
Kažkaip čia bando atimti kažką, ar ne, bando kažkaip pakeisti, moralizuoja, jaučiasi labiau išgirstas ir priimtas.
So the therapist should feel accepted and understood. And if you are more open to your convictions, you're more open to the client, and you are more aware of the possibility that you might lose the client. Another important thing that should be considered is the limits of responsibility. Of course, the therapist needs to use all his or her professional competences during therapy, but a lot depends on the client and the client's responsibility. The client should also assume responsibility for their lives. So being aware of that responsibility helps in the event that the client later commits suicide. And if you don't answer to certain questions, well, you need to determine what you are responsible for and what you are not responsible for. What is my task when working with this client? What are my expectations with regard to myself? Aren't those expectations too high? And what are my expectations towards the client? Are they too high or too low? So answers to these questions are very important, and when I work with my clients, I usually ask myself, what kind of task do I set to myself? So the task is usually to help the client to see a wider perspective, that there is a possibility of death, but there are also other possibilities in life. So I try to expand the client's thinking and make the client see more possibilities. On the other hand, my task would be to help the client to reconsider the process that he or she is going through, maybe to help the client to prepare a safety plan. So all these things should be considered, and we should accept the possibility of our clients dying by suicide. And we should also remind ourselves that even if I'm the most competent, the most reliable, and the best specialist, you have your limits. So I believe that it is important to be aware of those limitations, and I should try and think whether the client lives or dies depends on me only, maybe not. So what is my perspective on this? I should also answer the question, how will I accept the possibility that the client will not want to change and will not get better? And we must be aware that a therapist is within the client's life for several dozen of hours. During the rest of time, the clients live their own lives. So if we need to try and understand whether we can change anything within those few hours. And we must be aware that we will not always be successful.
Esu patyrus.
I have experienced the losses of 5 patients, and last week I calculated that during my years, 20 years of experience, I have consulted approximately 600 patients, and when they got discharged, I probably didn't even know what happened to them. But I hope that I will probably have helped more people than I have failed to help. Therefore, it's worth making an effort and believing that I can do, make an influence, make an impact, cause a change in their lives. But of course, every loss is a pain, and it remains in your memory, and you accumulate the cemetery in your brain, and probably you need to get ready to that and prepare yourself. Maybe this is part of my professional and personal life, and that's it. And I have to stay with that. Because when you think about people in the risk group, you really really have to evaluate yourself realistically, and you have to not forget your own resources and limits. Thank you so much for listening.
Thank you, Vaiva, for such a warm and empathic presentation. We welcome now Jacinta as well to our discussion team. Hi, Jacinta again. And there are a few questions following both presentations. One question is about support in the organization. Is it a usual practice in Lithuania or in Australia that an organization has a policy how to support the clinicians in the organization following bereavement by Susan, following a client's death? How should that occur? How should the support be organized? Should it something that be coming from top to bottom? Should directors or ministry implement any policies that people should do that, or is it something that has to come from the clinicians themselves? So it's a two-part question. How is it done? Is it done? And who should organize it? Which one of you would like to start?
Well, okay. First, I want to say thank you for that excellent talk. Viva, it was excellent. Thank you. So in Australia, I can only speak from, because to be honest, I don't see a great deal of commentary in the literature around precisely what is available and where and what disciplines it is and is not available, etc. However, look, to my knowledge, that there are a lot of workplaces, particularly government departments, that have what we call sentinel events responses, and typically these are developed based on death of a client of any nature of cause of death in hospital settings and government departments. So I've not yet come across a particular protocol or policy specifically tailored in a government department to the aftermath of client suicide, which does not mean that they don't exist in some places, but frequently I have been called upon into workplaces to assist in the development of protocols to be able to have something in place. To the extent that these should be developed from the top or the bottom, top down, bottom up. I think the ones that are available have come from the organisation themselves, from the top down or policy divisions, etc., of the organisation. But I really believe with our increased emphasis on lived experience and the importance of co-design and the leadership that we've seen witnessed, and increasingly so recently, with where to direct our responses, particularly even for this situation. I think it's important that we look to lived experience for this, but not to the detriment of or neglect of looking at evidence and the literature. And so I think there should be an evidence-informed as opposed to evidence-based RCT standard response to being able to build up policies that are effective. That's, my thoughts on that.
Jo, gal dar pridėt norisi irgi.
And I will also add, I do agree.
I also think that the both parts are very important. That this organizing help for specialists, not only when they are bereaving or grieving after the suicide of the patient, but also when they have some emotional, difficulties in their job, that they could get the support, could get the help. But it goes both sides, I think. If there are a need goes from the bottom, so there should be something from the top that covers that need. Maybe thinking like that, because when a specialist feels a need and they know that there is no opportunities to get some help, so they do not use it because there is no such a policy. So it's maybe there's a broader thing to think about, just to raise this question about the policy, about the need for specialists to get some emotional support when they are in need, not only for mental health specialists, also for other health specialists, because they also meet deaths of patients.
Yeah. Can I just add something to that? I love that idea that one needs and benefits from the other as well, and they need to work in synchrony. And to extend that a step further, perhaps even being able to liaise with other departments, because a lot of times clients are delivered services in a psychosocial kind of wraparound sort of framework of response. And so there's more than just even the initial client, but especially for longer term clients that are impacted. And one of the things I found particularly helpful just myself, finding a response. I'm in private practice as well as at the institute. So but when you're very private, you don't have policies and procedures and any sort of scaffold, which is why I love the point that you made earlier about collegial support and discussion, etc. That's obviously extremely important. But one stakeholder who would be critical, I would think, in building up a policy of support in an organisation would be the coroner's office. And so I found a great deal of support in getting educated. Now I run workshops for our coroner around suicide risk assessment, but getting support from the coroners around and magistrates around how they respond and deal with the aftermath of suicide with a client who's in the government system or the private setting, etc. And they're quite nurturing. At least I've been quite fortunate to meet quite nurturing ones where they have enough compassion around the difficulties and impacts on workers. Yeah.
Well, thank you, Jacinta. I think you mentioned an important point, because in Lithuania we don't have a coroner, and it sounds like it's something that ties this link nicely between like the health system and the police system who are doing the investigation following death. So thank you. That's a helpful idea. Another question raised from the participants was about information about the client's suicide. Should the clinicians be informed about it in any systematic way? Would it have any benefits or any drawbacks? What's your experience?
I'll let Vaiva know first.
Yes, I was thinking about this question quite a lot. Yes, because there is also two-way two-way road. Again, um, on the one hand, for the clinician, it would be really helpful to know if the patient you are working recently or you are working now committed suicide or died other way, because you just stay in this unknown. You don't know what happened. You don't know why. Just patient didn't come, or and that really doesn't help to cope with emotional difficulties in this job, because that raises quite the difficulties. But on the other hand, should we know about all the patients? Should we know about the recent patients? What that would give, what that would change actually? So I think that looking from the perspective, from the specialist perspective, that would be really good to get some information, some normal information, and not just informal information from other patients, for example, or from some gossips you hear that something happened, but to get some formal information that this and this, your patient who was in the hospital committed suicide, someone, because then that could legalize to talk about that in institution, inside the institution and inside the team, because otherwise it's just not a real information. So looking from this part, but should we know about the other patients we worked 10 years ago? Maybe not. And of course there are some confidentiality and other questions here, anonymity, confidentiality, systemic questions here.
Yeah, sure. I think that's an important point about the time period, and I think it's trying to identify a particular point at the point of discharge or referral, etc. It can be a little bit arbitrary to some extent, trying to make a decision. But on the other hand, if we go to, for example, once you've wrapped up a case, for example, if a client's no longer on your books, you can be guided by some of the ethical guidelines that help us understand point of care and caseload, etc. And so organisationally, I can imagine that there could be decisions made simply to that end around the end of a case, then there's no responsibility for the organisation to feed that material. However, in the real world, I think the period during which the referral process is happening, and we know that there's like a 100 to 200-fold increase of suicide at post-discharge for people admitted with psychiatric and suicidal behaviour, and that these happen greatest now in the third day after discharge, as opposed to what used to be 15 odd years ago, the first day. So I would see that these periods when we're trying to get people placed into community care or case management, etc., are important periods to learn lessons, as well as to have an interest in systematically what potential, if there is any potential opportunities to be able to further support patients in that period. So yeah, to an extent, as a private practitioner, I would, once I'm finished with a client, I probably, not that I wouldn't be interested in knowing the outcomes. Some of my clients, whether it's good or bad outcomes, of course, there's always an interest there. But in terms of regulatory responses, from a coroner, as in our country, I probably would see it would be not possible. And but definitely, I believe we should be informed when they're within our practice, even if the case isn't closed. It's really, I would think, a more ethical requirement to do so. Yeah. So some certainty and some grey in that, I guess.
Thank you so much, and thank you both of you for raising this important topic, talking about it so honestly and openly, and so warmly. I'm really grateful for you both agreeing to be here today. Unfortunately, we have ran out of time. I'm sure we could speak more and more about this topic, but I'm glad we raised it, and I'm sure people will keep this in mind and try to find ways how to find the support, who could be their support network, and how they could support themselves if unfortunately such events happen. So thank you both. Good luck and all the best. And I hope to see you in other conferences.
Yes, thank you
Thank
so
you.
much. Thank you.